Hello, my name is Dr. Diwan S. Raja. Today I will discuss about congenital adrenal hyperplasia. The congenital adrenal hyperplasia consists of a group of autosomal recessive disorder characterized by defect in the steroid biosynthesis, especially the cortisol. Okay, so the congenital adrenal hyperplasia, also called CAH, this consists of group of autosomal recessive disorder of the biosynthesis of steroids, especially the cortisol. Okay, we got the definition of the congenital adrenal hyperplasia. This problem is associated with a group of autosomal recessive disorder of the biosynthesis of steroids, especially the cortisol. Okay, so we have some enzyme defect in this patient. We have some enzyme defects. Okay, enzyme defects. Most common enzyme defect is the 21 hydroxylase. Okay, most common defect is the 21 hydroxylase. We have other enzyme deficiency like 17 hydroxylase deficiency. Another one is 17 hydroxylase deficiency. Another one is 11 beta hydroxylase deficiency. Another one is the 11 beta hydroxylase deficiency. So we have deficiency of enzymes, so we have defect in the biosynthesis of the steroid, especially the glucocorticoid, especially the cortisol. So this is most common 21 hydroxylase deficiency, and this is around 90 to 95% cases of congenital adrenal hyperplasia. Okay, so we got most common is the 21 hydroxylase deficiency. If we look at the synthesis of the cortisol, there is the glucocorticoid and the aldosterone, the mineralocorticoid, that is, we'll start from the pituitary gland. And pituitary gland has anterior part, posterior part, anterior pituitary, posterior pituitary. From the anterior pituitary, we have secretion of ACTH or adrenocorticotropic hormone that work on the adrenal gland, adrenal cortex. This is adrenal cortex, this is adrenal medulla. ACTH work on the adrenal cortex. In the adrenal cortex, we have the synthesis of the cortisol and the aldosterone, and also partly the sex hormone, mostly the cortisol and aldosterone. So from cholesterol as a precursor, we'll get the pregnenolone. Then it will be converted into 17-hydroxypregnenolone. Okay, that will be converted into 17-hydroxyprogesterone, deoxycortisol, 11-deoxycortisol, cortisol, that is the glucocorticoid. Okay, from the pregnenolone, okay, from the pregnenolone we had the progesterone, then there will be formation of deoxycorticosterone, aldosterone and mineralocorticoid. So these two hormones are coming out from the adrenal cortex, and adrenal cortex is a part of the adrenal gland. Adrenal gland is located over the kidney. It is also called suprarenal gland. Okay, so we have defect in the enzyme, may have multiple enzyme may be defective. Okay, the most common is 21 hydroxylase deficiency. So this is the common site from progesterone to 11 deoxycorticosterone is hampered because of blockage of conversion of progesterone to deoxycorticosterone due to lack of 21 hydroxylase enzyme. Another place here, 17 hydroxyprogesterone to 11 deoxycortisol is not possible because of blockage at this level due to lack of 21 hydroxylase deficiency. So if the glucocorticoid is not produced or mineralocorticoid is not produced, what will happen? Then this intermediate product will be converted into the sex hormone or sex steroid, okay, like testosterone. Due to the action of the adrenocorticotropic hormone, it is not going in that direction. It will be converted in this way to become testosterone or sex steroid. Okay, so if this is the condition, what will happen? In a newborn, especially in the female, we'll get ambiguous genitalia. In female newborn, we'll get ambiguous genitalia. Okay, like what? We'll get enlarged clitoris. So enlarged clitoris or clitoris. Okay, and there will be fusion of the labia majora, fusion of labia majora, and the urethra may come from the clitoris. Okay, so and there will be protein deposition under the skin of the labia majora. Okay, so we get this feature. We call it masculinization. In female, we'll get ambiguous genitalia, and the cause of ambiguous genitalia in a newborn female, most common cause is congenital adrenal hyperplasia, and most common cause of congenital adrenal hyperplasia is 21 hydroxylase deficiency. Okay, so we got this problem, plus we get hirsutism. Hirsutism Okay, as the child grows, they will develop hair in unsightly places. Okay, overgrowth of hair in unsightly places. Unsightly places in the female. Okay, so we get hirsutism. Okay, we get oligomenorrhea. That means decreased menstruation, irregular menstruation, and there may be infertility in most cases. There may be infertility. Okay, so we got this is the problem associated with congenital adrenal hyperplasia to the newborn female child. How about the male child? So in case of female newborn with congenital adrenal hyperplasia, diagnosis is very easy because of ambiguous genitalia, masculinization of the female. Okay, so how about the male newborn? In male newborn, it seems to be normal appearance at birth. Usually it is unnoticed. If it is not a salt wasting type, so if it is associated with salt wasting, there may be some type of crisis, adrenal crisis after 2-3 weeks later because of loss of sodium, salt wasting. So both male and female, around 25% cases. Okay, congenital adrenal hyperplasia is salt losing type. Okay, salt losing type. So there will be loss of sodium, so patient will develop hyponatremia, patient will develop hyperkalemia. Okay, the patient will develop dehydration. This lead to adrenal crisis. So if it is in the male, it may be unnoticed. If the male belongs to salt losing type, lack of mineralocorticoid along with glucocorticoid, then we may get the adrenal crisis. 2 to 3 weeks after birth. Okay, so one type of congenital adrenal hyperplasia, mostly defect in the glucocorticoid cortisol, but around 25% cases it may be associated with that of the mineralocorticoid deficiency also. So we get adrenal crisis. Okay, we got that. So as the male child grows up, and also in female, there will be precocious puberty. Okay, precocious puberty. Okay, there will be rapid growth in early stage. Okay, so there will be precocious puberty also in female. There are also early onset of in female there may be also some type of reproductive problem, but in male that is the precocious puberty. Okay, that is common, and there will be bony ossification growth very quick, both male and female. That is a possibility. Okay, so we got the precocious puberty, enlarged penis in male, enlarged penis in male child, and it is precocious puberty that may happen. Okay, we got that. So what are the differential diagnosis? differential diagnosis. It may look like that in case of female, it mimics that of the polycystic ovarian disease. Polycystic ovarian disease. Or there may be some adrenal tumor. Pseudohermaphroditism. Pseudohermaphroditism. Okay. And there may be testicular tumor, maybe in our differential diagnosis, testicular tumor. Okay, so we got differential diagnosis, and it may be possible to diagnose congenital adrenal hyperplasia in a fetus by doing amniocentesis and chorionic villus biopsy. We can study and we can manage even in case of female fetus with congenital adrenal hyperplasia can be managed by steroid intake of the mother. Mother can take steroid that may prevent the genital ambiguity in a female fetus. Okay, we got the differential diagnosis. So what is the problem? Problem is that due to lack of production of cortisol lack, mineralocorticoid lack, that will stimulate the anterior pituitary to produce more ACTH because of this feedback mechanism. If these are less glucocorticoid or mineralocorticoid, then by feedback mechanism, the ACTH will be released from the anterior pituitary. Okay, that will stimulate this system and it will increase the level of sex steroid. So this is the way it works. Okay, so we got that. And what other changes? There will be adrenal cortex hyperplasia. Hyperplasia due to excessive adrenocorticotropic hormone secretion from the anterior pituitary. It will be hyperplastic. It will increase around 10 to 15 times. 10 to 15 times it becomes heavier than normal. Heavier than normal. Okay, it is large. It becomes large. 10 to 15 times it becomes heavier, or its weight is increased nearly 10 to 15 times than that of the normal adrenal gland, adrenal cortex. Normal adrenal cortex. Okay, we got that. So that happens. And if you have cut section of the adrenal cortex, we will see it is brown color because lack of lipid from the adrenal cortex. Color will be brown. We got that. Now, how to manage a patient of congenital adrenal hyperplasia? Okay, it can be managed by replacement. We can give steroid management, as because lack of glucocorticoid, lack of mineralocorticoid, replacement of glucocorticoid and replacement of mineralocorticoid. If it is only the problem of glucocorticoid, then only glucocorticoid. If it is a problem of both glucocorticoid, mineralocorticoid, we will give replacement therapy with steroid. Steroid replacement, like that of cortisol and fluodocortisone. Okay, fluodocortisone and cortisol in the management of the congenital adrenal hyperplasia, and plastic surgery to the female child. It should be done around 1 year ideally. So we can do plastic surgery. Plastic surgery. Okay. So that's all about the congenital adrenal hyperplasia. If you like my video, please support my channel. Please subscribe me, share the information with your friends, and have a nice day. Bye now.